is really important, because sometimes patients come and they've got a radiolucency that you're seeing on a radiograph, and they're getting pain to hot and cold, and actually, hold on, that if I do the root canal on that tooth, it's not going to fix that patient's symptoms, because their main complaint is pain to hot and cold, which is going to be a vital tooth, not something that's necrotic and has a lesion. So starting from patient history is really, really important. In terms of when you're looking at the patient clinically, it's all the standard tests. So the first thing I do is the tooth tender to percussion. And you always want to start with a tooth that's not tender first, so they get an idea, because you will get some nervous patients that will just jump if you tap their tooth and you think, okay, that's the tooth that's hurting. So always start with adjacent teeth which are not tender, and then move on and compare the tooth that you're testing to that. So tender to percussion, tender to palpation, so whether that's buccally, palatally. You always want to look at pocketing around the tooth. So it's a little bit different to doing a BPE when you're checking for pocketing for endodontic purposes. You want to get a narrow probe, so something like a Williams probe, not a bigger probe with a round head on it, so not a BPE probe, and literally walk it all the way around the gingival sulcus, so in tiny increments. And what you're looking for is things like an isolated pocket, because that could indicate a crack or vertical root fracture. Pocketing. Next is sensibility testing. So you really want to look at cold and EPT. Cold, I know at university we were always taught ethyl chloride. I don't know what you guys are taught, but is it ethyl chloride still? I don't know.
Ethyl chloride, endofrost, those two, isn't it?
Yeah, so there's a massive difference between ethyl chloride and endofrost. So ethyl chloride is -5 degrees Celsius, which isn't very cold actually if you think about it. And endofrost is -50 degrees Celsius. So you're much less likely to get a false reading when you use endofrost versus ethyl chloride. And EPT for me, again, if something's not responding to cold testing and I'm expecting it to, I find EPT really useful. And again, starting from an adjacent tooth that's is vital, and moving on to that tooth, to the tooth that you're testing. Radiographs, so getting a really good radiograph, a parallel radiograph, all of these things are really good for getting a good diagnosis.
Would you use both EPT and cold testing when you're doing the vitality testing?
I do for things that appear calcified. So for example, if we're looking at a molar that has very calcified canals, calcified pulp chamber, sometimes those teeth you do get false readings with cold alone. Whereas EPT, for me, I find it a much stronger stimulus. So I will always check it with those cases with EPT where I'm not 100% sure what's going on. I will check those with EPT as well.
Okay, nice.
And in terms of radiographs, so when would you say a CBCT is indicated for which cases?
So cone beam CT is a 3D scan of a tooth, and it's got so many applications in endodontics. So there's been so much research over the last sort of 10, 15 years about how CBCT is relevant to endodontics. One of the big things is diagnosis. So if a patient has come to you with signs and symptoms which are a bit difficult, so a bit contradictory. So for example, if they've got pain in a quadrant, they're not sure which tooth it's coming from, a cone beam CT can be really useful, because on a periapical radiograph, you might not see a radiolucency associated with a tooth, but on a cone beam CT, because it's a much more detailed X-ray, quite often you see, okay, there is a lesion on that tooth, which we can't see on the radiograph, but on a cone beam, it's picked up. So anyone that's having difficult signs and symptoms, you're not sure which tooth it's coming from, a cone beam CT is really good. It's very good for looking at anatomy. So if a tooth has complex anatomy, for example, upper molars with MB2s, dens invaginatus, it's really good for that sort of looking at that anatomy prior to going in. It's great for endosurgery because it helps, again, with the anatomy. You know how the tooth lies in relation to the sinus, to the ID nerve, again, which tooth the lesion is coming from. So for example, if you've got an upper molar, you might obviously be able to see that there is a lesion on the MB root, but you might not have seen one in the DB root. So if you're going to plan surgery, you really want to have all the information before you go in. Also things like resorption. So internal resorption, external resorptions, you can see exactly where the resorption is, so you don't get confused. You can see how big it is, because we know on an X-ray, if you see any sort of resorption, it's going to be a lot bigger than it actually is in the mouth. So it's going to be bigger, sorry, in the mouth than it is on the radiograph. So cone beam CT is really good for those things. And also things like trauma. So we often miss things like fracture lines, bone fractures on a radiograph, whereas on a cone beam CT we can actually detect these things. So it's fantastic for a lot of reasons.
And we've got a question in the box, so from Ahmed. So what are some important points when looking at radiographs in particular?
So I guess, like, if there's a periapical radiolucency, that's really important, because we know that teeth with lesions, even so if teeth with lesions have a lower success rate slightly when it comes to endodontics, those with large lesions as opposed to small lesions again have a lower success rate. So if there a lesion, the size of the lesion, also the anatomy. So I quite like on a preoperative radiograph to measure where the pulp chamber is. So for example, if you take a radiograph, I look at where the occlusal surface is and I measure to where the pulp chamber is with a Williams probe. So you know roughly how many millimeters it is. If it's a digital radiograph, you can measure it digitally, obviously. And then you can translate that measurement onto your burr. So when you're accessing, you know roughly how deep your burr should be before you're going to hit the pulp chamber. And I know we're going to talk about perforations later, but that can be really useful. You want to look at the canal anatomy. So is it curved? Is it straight? How patent the root canal is. So is it calcified? Are you going to, is it going to be difficult to locate that canal? Any resorptions? So yeah, quite a lot that you'd look at your radiograph for.
Yeah, I think
you mentioned a large pathology gives a poor prognosis. What is a like a larger pathology?
Yeah, I mean, they don't say. There's just been studies that have been done which have looked at success rate for root canal treatment. And a small lesion, I guess, would be a couple of millimeters around the root surface. Anything larger than that, so larger than I'd say 5-6 millimeters, is getting larger. But obviously you can get really huge lesions. And again, those ones are, although you would still do root canal treatment and the success rate is still quite good, so maybe 75 to 80%, it's never as good as if you're doing a root canal treatment on a tooth without a lesion or with a small lesion.
I think measuring it beforehand, that really helped me, because I think when I first started doing it, I used to take like hours trying to gain access because I was just so worried of going little by little. But then if you know exactly like how much you need to go, then it just makes it so much quicker, I thought.
Yeah, 100%.
So is there any difference between sensitivity test and sensibility test for pulp testing?
They're the same thing, they're just different names. Yeah, so what that indicates is that we're testing the nerve supply in the tooth. So it's never a great terminology to say you're doing vitality testing, because vitality testing means is that tooth alive or not, whereas sensibility or sensitivity testing means that we're testing the nerve supply rather than the blood. Is there a blood supply in the tooth? We're actually testing the nerve supply.
Fab. Okay. Right, let's go into, okay, so I've noticed that on some of the, when you've been putting your cases on Instagram, you've done like a poll on whether you would extract or whether you would like save the tooth a lot of times. So I think that's obviously quite a big topic that everyone wants to know, whether to either do the endo or extract or refer. So what indicators or factors do you look out for when trying to decide which one to do?
So the first thing is how much tooth tissue is left. So for an anterior tooth, or anything up to a premolar tooth actually, we want at least a 2 millimeter ferrule around the tooth, which means that there's 2 millimeters above the gingival margin that you could then put a crown on. So those, when there's not very much tooth tissue left, obviously we'd need to put a post inside the tooth. So for a tooth like that with only 2 millimeters left, we'd need a post, but it does mean that that tooth is then restorable. So for anterior teeth up to premolars, we can get away with not having as much tooth tissue left. For posterior teeth, obviously we're going to have a lot more occlusal loads on those teeth, so we need more tooth tissue left if possible. There's no hard and fast rule. It's more something that you'd sort of go through with images. So I teach this topic to DF1s, and we normally have loads of photos and say, do you think this is restorable? Do you not think this is restorable? But a lot of it is how much tooth tissue is present above the gingival margin. The other way that we look at it is how deep the caries is. So with biological, I don't know if obviously you guys learn about biological width, but ideally, you know, you want like a millimetre or so above bone level in order to restore these teeth predictably. You can, so for endo, we are normally dealing with teeth that are really broken down. So quite often we do encroach a little bit on biological width. So rather than doing crown lengthening, which a lot of people won't go through, they'd rather have the tooth extracted. We can use certain methods. So use, for example, matrix bands called deep margin elevation bands to sort of build up teeth a little bit more broken down than we normally would. So it's really a judgment call for a lot of these things, which is why I post a lot about them, because at university we were always taught, you know, if it's slightly broken down or slightly below gingival level, then it's not restorable. But actually a lot of these teeth we can save for a lot longer if we have the right methods to do it. So really it's a judgment call, but based on how much tooth is left and how deep the caries has extended.
Do you use any like guidances to judge how restorable a tooth is, or is it mostly just clinical experience?
I think it's more clinical experience. There is a lot of guidance systems out there, like restorability indexes and things like that. And I think you do need to know about them. But most of this sort of thing is from a is from an experience level. You also have to look at the functional cost. So, for example, for upper palatal, lower upper palatal, upper palatal, lower buccal, you know, you need to look at where the functional cusp is, because if you've got more tooth tissue where that functional cusp is, you're more likely to try and save that tooth. So for example, if we're looking at an upper anterior tooth, if we've got, for example, 4 millimeters of palatal tooth tissue and maybe 1 millimeter of buccal tooth tissue, you're more likely to try and save that tooth because the functional cusp has more tooth tissue present. Does that make sense?
Yeah.
Yeah.
So I think it is a little bit of a judgment call, and it's quite a long conversation to go through a lot of these scenarios. But you know, I'd say there's no hard and fast rule. A lot of it is experience.
Okay.
Okay, so we're going on to isolation now. No one's got any other questions, have they? No. Okay, so this was actually my question, because I had such a big problem one time when I was doing an upper left 7. And I probably shouldn't have taken it because I think it was probably a bit too hard for me to do, but I tried and I succeeded after a long time. So I don't know about other unis, but in Manchester we normally do our like endos over like 3 sessions, and I think this took me like 5 or 6 because I wasted like about maybe one full session and then a little bit of another just trying to figure out how to isolate this tooth, because there was just nothing for the clamps to hold on to. It just kept pinging off, and then I tried to put composite on it to try and create like a bulbosity, but then because I couldn't isolate it, then there was like moisture there, and then the composite kept flinging off, and it was just absolute stress.
Yeah, it's hard.
Yeah.
I feel your pain when you're saying it.
Yeah, literally. So have you got any sort of advice in that sense? Because I can appreciate like there's when you've done you know, cases right at the back of the mouth, and it's also so hard for the patient to keep their mouth open as well. But you kept like the minute he like slightly opened closed his mouth, it just pinged off again.
Yeah, it's hard. I think this is the main difference that the main mistakes that I used to make before I did my specialist training. So I used to want to jump in and do the endo, so I would remove the caries and then try and isolate that tooth.
Yeah.
Now if you can't keep a rubber dam on, the first thing is that tooth restorable? Because if there isn't enough tooth tissue to hold a rubber dam clamp, you do seriously have to think about, is there enough tooth tissue left to keep this tooth long term in function? So that's the first point. If you think there is, then what I would first do is do a pre-endo build-up. So what you do is you take out all the caries, put on your matrix band, and actually build the tooth up in a composite first, or an amalgam, or whatever you're going to use for your core. So do all that first, and it's a bit frustrating because it takes longer to do this because you're suddenly having to do this restoration, which you know you want to get straight into your endo. But take a step back, put a pre-endo restoration in it. So it's basically like just a build up all the way around, so you get a 360 restoration in the tooth. And then your rubber dam will be really easy to put on, because then it'll be sitting on your restoration. Is that what you did in the first place, or did that keep clinging off?
I think in that sense, I literally just put like a little bit of composite like on the sides, like just a slither. So then I think that just kept flying off because there wasn't that much of it to actually hold on to. So I think, and then a consultant ended up having to sort that bit out for me.
I mean, that is one way. You can use like composite to hold your rubber dam on, but if you've actually built up your tooth, like for example for you, because that took you 5-6 sessions, if you just spent that first session doing that pre-endo build-up, that would then have, it would have been so much easier. And the pre-endo build-up is really useful for lots of different reasons. One is that it supports your temporary filling. So if you can imagine a 360-degree filling on, part tooth, part filling, you then access through the middle of that. So when you put your temporary on inside the tooth, you've got a really good seal, because, for example, with yours, it may be that temporary filling kept coming out midway through, midway into appointment, midway. The other really good reason is if you have that 360 sort of build up, then your irrigants stay in that middle bit in your access. So every time you're irrigating and you're putting your hand files through that, it's passing through a pool of irrigant and going into the canal. So that's really good. So lots of reasons to do it. Also, your hypochlorite doesn't get, doesn't leak past your rubber dam into the patient's mouth, which is obviously slows you down. So all these different reasons are great reasons to do a pre-endo build-up. I do it for every single case. So as soon as I see a patient, their restoration comes out, my first thing is I'll get a matrix band, do the build-up, then I'll put my rubber dam on and do the root canal treatment. And at the end of treatment, you're not having to rebuild the whole tooth back up. You're literally just having to do the middle bit of the access cavity. So it saves time later on, but initially it feels a bit frustrating having to go through this before, but it saves so much time. You also figure out if the tooth's restorable, because if you can't get a matrix band on, actually that tooth probably isn't restorable because it's not going to have a good seal long term. So you get all that information before you do the complex part of the endo, and then
That's really good tip. I've never heard of that before.
It's a really good way of doing endo. Because part of it is the lack of control with endo. If you're having your hypochlorite leaking and saliva leaking through your rubber dam, all of that makes you feel really out of control and makes you not enjoy endo. Whereas if you've got this pre-endo build-up, if you've got this pre-endo build-up, you're pretty much, everything's relaxed when you're doing your treatment.
It was the biggest stress. I think that was like the worst experience of like my life. Because even when I went to go, I think we're going to talk about this later, but when I had to take my patient to the x-ray department to get x-rayed, like it just kept flinging off, like when I was about to take, and it was literally just like, it's bringing, because
you're like stressed the whole time and you want to take all the stress out of it. So this just makes sure that you've got a fantastic seal on your rubber dam, your tooth's restorable, everything is sorted.
Sure, I'll definitely remember that before I take a posterior case next time.
I'll be doing that too. I mean, when one thing goes wrong, it all starts going wrong, doesn't it?
Yeah. And then you get annoyed with your patient because they've bitten down on the clamp and it's flung off, and you're like, why? You just need to. But you can try a bite block if you have a problem with that as well.
Yeah, because when that happened with mine, the clamp, like, because I put floss around it, because you're meant to do that, so it doesn't. I couldn't find it, and I was like, "Did you just swallow it?" I literally thought he'd swallowed it, and I started having like my whole career just flashed before my eyes. Like, swallowed this clamp, but it was a huge one. But he didn't. It was on the floor. It's fine. Anyway. Okay, so moving on.
We've had a question in the chat.
Okay. Is it necessary to restore a posterior RCT tooth with a crown?
Yeah, it is. Yeah, so there's lots of evidence that a cuspal coverage, so not necessarily a crown, but something to cover the cusp, so it could be an onlay, really improves the success rate for posterior teeth. So anything from a premolar backwards. There's really big studies. So if you want some, Salarabi and Rothstein is one of the really big ones. And they showed that, so what they did is they did a study with looking at root treated teeth that had been extracted and why they'd been extracted. And the majority of them was because they had fractured, and 85% of those didn't have a cuspal coverage restoration. So it's a really good study to quote. It's based on 1.5 million patients, so a really sort of solid study that you can quote. So yeah, all posterior teeth, premolar backwards, should have a cuspal coverage restoration, apart from if they have all the marginal ridges intact. So we don't often see this. If they've only got an occlusal access and all the marginal ridge is fine, then you can debate whether you want to do it or not. For me, if the patient's a parafunction patient, I will still place a cuspal coverage on afterwards. But if they are a very young patient, no bruxism or anything, then I may consider not doing it for that specific circumstance.
Okay, yeah, that makes sense.
Would you cover all the costs, or could it be like a 3/4 crown or something like that?
All of them. All of them. Yeah, because what happens is when they're biting, the tooth will flex. So if you've covered half of it, it's still going to be flexing on the other one, and you will end up with fracture of the other one. So it should cover everything. Ideally, you don't want to be putting crowns on these teeth. If you can get away with an onlay, it's so much more conservative. So yeah, I'd say, onlays are best.
Yeah.
So we'll just moving on to the questions that are about access. So tips for accessing a lower incisor, please.
So lower incisors for me are the hardest teeth to treat in the mouth, much harder than a curved upper 6 or an upper 7. They're really, really difficult because you don't have a lot of room for error. So the question's a really good question, because obviously it's you want to be really careful in terms of your angulation and things like that. So I normally go in with a round burr to start with, a very small one. You go in just above the cingulum. You want to orientate your burr parallel to the front surface of the tooth. So if your surface is like that, your burr should also be exactly the same angle as the front surface of the tooth. And that's how you know that you're going in the right angle. The most common place to perforate is buccally, because normally if that's the front surface, people go in at this sort of angle, and then they're going to perforate buccally. So looking at the angulation, so starting with a round burr, then moving on to a tapered burr, again checking your angulation, knowing the depth of when you're expecting to hit the pulp chamber. So again, using the measurements from your preoperative radiograph, transferring them onto the burr, and knowing the rough number of millimeters it will be until you're hitting the canal. Normally, if you use a probe as well to look at the angulation, so normally what I do is I use my tapered burr, go into roughly the depth I think I'm meant to be, and then get a really sharp DG16 probe. So do you guys use that?
Yeah.
So DG16, so DG16 probe is a little bit different to a normal dental probe. It's a lot longer and a lot sharper. So it's much easier to detect canal orifices with the DG16 probe, but rather than a dental probe, which is a little bit shorter and not as sharp, so you can't really feel exactly where it is. So once I've gone in with my tapered burr, I'll then switch over to my DG16 and have a little feel and try and sort of penetrate into the pulp chamber. And again, with your DG16, you can use that as to compare the angulation to check that you're at the right angle, not going too far mesially, distally, buccally or lingually. So that's really what I do. You're most likely to drop into the buccal canal first. So for lower incisors, 60% of them have one canal and 40% of them have two canals, which is quite a high percentage if you consider what a tiny little tooth this is. So the one that you're naturally going to find will be your buccal canal. So normally I'll fully prepare that first, and then I'll use Gates Gliddens just to gently brush back the lingual aspect of the tooth, and then try and look for the lingual canal.
Okay. I think this was one of our questions in one of our exams, one of our papers, about whether you gain access and then put the rubber dam on, or you put the rubber dam on first and then gain access. And I think I've heard from different tutors different things, that firstly you should gain access like a little bit, but without going into the pulp chamber or anything, just so you know you're going in the right direction, and then you've got a less risk of going completely off and perforating. But then other tutors have been like, no, you do not start at all until you put your rubber dam on. So what would you say?
So there are mixed opinions there. I can't give you the right answer, but I can give you the pros of what I do. So I tend to access without my rubber dam first. So you don't ever want to use files or anything like that, obviously. This is just literally with a burr and with a DG16 probe, okay? And the benefits of doing that are, firstly, the amount of people that accidentally put rubber dam on the wrong tooth and then try and access is you think it sounds simple, but it's crazy how many I've seen postgrads do it. So it's so easy, because once you've isolated it, you can just see one tooth sticking out. You think that's the tooth that you're working on, and you just drill into it. So if you've sort of gone in without a rubber dam first, you know if it's a 6 or 7. Do you know what I mean? You're not going to get the rubber dam on the wrong tooth. So that's one big benefit of doing it without. The second, again, is angulation. So exactly what you talked about. Once you put your rubber dam on, you lose a lot of the anatomy of the tooth. So I find it a lot more difficult to see depth. I find it difficult to see exactly where I am in the tooth. So I like to gain access without rubber dam first. Then as soon as I sort of roughly just penetrated into the pulp chamber, then I'll put my rubber dam on. Now, some people, for necrotic cases, there's not really an argument against doing that. For vital cases, so for a tooth with irreversible pulpitis, for example, what someone might say is, oh, you know, that pulp is vital, you've had no bacteria in it, and then you've accessed it with saliva obviously around, and you've now got bacteria in the chamber where previously there wasn't very much bacteria present. I think that, to be honest, it makes very little difference, because you just gain access where you are. Once the rubber dam goes on, you're going to put hypochlorite straight into that area. You're not going to instrument too much into the canal, so you're not going to be pushing bacteria further down or anything like that. You're straight using hypochlorite. So I think personally, I don't see that being much of an issue. I think the benefits of getting your angulation right far outweigh the negatives.
Yeah, that makes sense. I'm interested with your angulation, because you know, you said you go parallel straight away. I read somewhere that you go 45 degrees, and then when you hit it, you go parallel and like clear it out or something. But is that only for upper incisors, or that you do what I just said?
Yeah, so the reason people do that is because they go 45 degrees to penetrate through enamel, because that's more difficult to drill through. But yes, you can do that and then align yourself, but your pulp chamber is never going to be at 45 degrees. It's always going to be a slightly steeper angle. The 45 degrees, what you've read, is just to get through the enamel, and then you retilt. I use my bearing straight away, so I go straight in, like I mentioned, at the right angle, at that sort of angle, parallel to the front surface. But people talk about 45 degrees just to penetrate through enamel, and then they'll align up. The reason, if you go 45 degrees the whole way, you'll end up perforating. That's exactly what happened to me, and unfortunately it was on a model, and I went 45 degrees and went way too far, because I didn't realise I was just taking the enamel away, but it was on a model. Yeah, that's fine. I've done it in real teeth, so you don't need to worry. But you just have to be careful with your angulation when it comes to that sort of thing.
What we've got now. So this was one of the top questions I think we got from quite a few people, was the best way to locate an MB2 canal.
Okay, so I've actually written an article. We'll go through it now, but I've written an article. I'm doing an endo column for dentistry.co.uk. So if anyone is really interested in this topic, it should be in the next month's issue. So there's loads of pictures and stuff and a video that might help as well. So have a little look. I'll also share. I've made a video about this, so I'll share that with you guys after this, so you can sort of show anyone that's interested. So the first thing you want to do is locate your main 3 canals and fully prepare them. So when you're going into an upper molar, forget about MB2 first of all. Prepare your platal, your MB1 and your distobuccal. Fully prepare it like you've finished your endo. Then go back and look for your MB2. So MB2 is really common in upper 6s, so upper first maxillary molars. You get them in over 90% of cases. Some people say up to sort of 98, 99%. So it's really, really common. And in upper 7s, it's up to about 60%. So again, more likely to be there than not be there. So once you found your main 3 canals, the most common place it's going to be is if you draw a line between MB1 and platal. So it sort of looks like that. Distobuccal will be here. So it's an imaginary line between MB1 and platal. Distobuccal will be here, and then you do a line perpendicular to that line, and that's where MB2 will be. So I know that's really complicated as I say it, but if you have a look at the diagram, I'll share you guys the video. It will become far more easier. So in most cases, that's where MB2 is going to lie. In some cases, it can lie closer to the platal or actually be within the MB1 orifice. So it can vary, but in most sort of 90% of cases, if you do the line trick that I showed you, that's where it's going to be.
Cool.
If you don't find one,
say that again.
I was going to say, if you don't find one, how do you feel satisfied? Do you not have it in the back of your mind that it's going to be there?
Yeah, yeah, exactly. That's it. When I don't find one, I sometimes don't sleep at night. So yeah, no, it is normally there. In most cases, it does join into your MB1. So a lot of general dentists won't even bother looking for MB2. But it's such a common canal, and it's such a common cause of failure for the maxillary first molar. It's a really important one to try and find.
My dad had a root canal, and he had to go about three times because they kept finding little like accessory canals and like other canals on one of his molars. So you're right with them. A lot of GDPs not looking for these extra things, because that's definitely what happened in his case, and he was in so much. Yeah. But he's all good now. It's all good. Yeah. Okay, so we've got tips for multi-rooted endo, which is kind of, and how to deal with poor vision.
Oh, sorry. Sorry. Yeah, so poor vision, so loops and a light. I definitely recommend you guys invest in yourselves and get some loops and a light. When I do, I'm mainly a postgraduate teacher at King's, but sometimes I do the undergraduates as well. And you notice the students that have that and don't have that, and they progress at such a different rate. So I know it's really expensive, especially as a student, but I think investing in loops and light will make such a difference to how you're going to learn endo as an undergraduate, and even as you come out. As long as you look after them, they last for years. So I've started with 2.8 oroscoptic loops, and they lasted me for about 8 years. Wow. So, you know, they last a really long time. And to be honest, they're still functional. It's just I've decided to change and move on to some different loops. Bryant dental loops are fantastic. I don't know if you guys have heard of those, but you can use a high mag. Yeah, have you got some?
I did, yeah.
Yeah,
no, I invested.
Yeah, you should. It's fantastic. I mean, if you look at some of the old school dentists, they'll say to you, oh, you need to get used to like using your eyes and your vision. That's just absolute nonsense. Yeah, it's absolute nonsense. Like, you just can't see, right? If you don't have the right equipment.
Well, my tutors at the moment kind of put me off using my loops, so I've still not really used them. But then when I listen to other tutors speak, they seem to use them for a lot of things that my tutors tell me not to use them for.
No, I use them for everything. A lot of general dentists use them for checkups. And the Bryant dental one's quite good because you have even though you go high mag, you still maintain a good field of view, so you can actually see most of the arch. What mag did you go for?
I was going to ask you this actually. What magnification would you recommend?
So I started on 2.8, which is a lot easier. I started on 2.8 as well. But the 5 times for Bryant dental, I think you will end up moving on to, and they do maintain. With the 5 times, you can actually see the whole lower arch or the whole upper arch with them. So I do think you'll hate me for buying the 5 times loops for sort of 2 weeks, and then you'll realize actually they're fantastic. So they're harder to get to use in the first place, but they're such a worthwhile investment. But yeah, I mean, so yeah, just definitely invest in yourself. I think molar endo is just really difficult to be, you just can't see what you're doing if you don't have the magnification and the lights. You can obviously use your vision, but I don't have any tips for you because obviously if you can't see, it's so difficult to do endo. So it's really hard for me to give you tips when you don't have that sort of magnification. Just try your best with your light and DG16 to be able to see. But that's my main problem with not having that, not having it, because it's just, if you can't see what you're going to do, it's really difficult to do endo without that. You can do a lot of other dentistry and get away with it without that sort of thing, but endo is just not one of those topics.
Fully broke my back trying to do my endos.
Yeah.
Would you recommend 5 times?
The other good thing is use a front surface mirror. That's a really important tip. So for most of dentistry, you'll have a rear surface mirror, and for endo, if you use that, you get a double image. So it's really difficult to be able to put your file into the canal because you're seeing almost two orifices. Whereas if you have a front surface mirror, you can actually see exactly what you're doing. The way you tell is if you get your mirror and you put your probe onto your mirror's reflective surface, your probe should touch your mirror directly like this. There shouldn't be a gap between when you touch your probe on your mirror and what you see. If there's a small gap, it'll only be like 0.5 millimeter. That's a rear surface mirror. So you want basically a front surface mirror.
Okay.
One of the old years told me to do that, and it was so helpful. Completely.
Yeah.
So what year would you recommend students get loops in?
I think when you start your clinical work, really. So probably year 4, I would say.
I need to get some.
Yeah.
You know, you said 5 times. Would you recommend 5 times for people who have never used loops before?
Yeah, it is difficult.
Really
yeah, I would. Yeah, because I think you're going to move on to 5 times and very quickly. So you're gonna get a bit annoyed. I mean, I had 2.8 for 8 years. Yeah, obviously I moved on to the microscope and stuff in the meantime, but I had 2.8 for ages, and they are very easy to get to use. I don't think you'll ever not use them, because you might end up using them for checkups and stuff like that. But whenever you do any sort of really high detailed work, you'll want the 5 times. And if it was another company like Oroscoptic, I would say definitely don't go for the 5 times. But with the Bright Dental, you still maintain a good field of view. So you can see a lot of teeth is what I mean. It's not just seeing 2 or 3 teeth. So you probably will migrate to 5 times fairly soon when you come out. Yeah. But you'll hate me for the first 2 weeks when you get them. You'll be like, oh my God.
Yeah. Because
she told me to get 5 times. I can't use them. Stupid girl. But you get used to them really quick.
Because they had like a tryout, and they had lots of different loops on her. I remember putting, it might be 3.5, and I put them on, and I was trying to do a crown pep, and I was everywhere. So that's why I went for the 2.8. But I should have just stuck out with it. So if you get 5 times, just stick with it, I guess. Yeah.
See what's good for you. 5 times are heavier as well. That's a big negative.
Okay, so so if a tooth has a crown on it and you need to do endo, what would you do?
So for me, I like to remove all the restoration before I do root canal treatment. Lots of reasons for that. So one is, if the crown's on the tooth, you don't know if there's any caries underneath. You don't know how much tooth tissue is there underneath. You don't know if there's any micro leakage or cracks. So there's a really good study which showed, it's by Abbott in 2004. What they did was they looked at restorations clinically and radiographically and saw, is there any leakage going on? And they came up with sort of, between 20 and 30 to 40% had some sort of leakage. Then they removed the restoration. So in our case, we would remove the crown and restoration. And they found that nearly 100% of the teeth had micro leakage underneath. And that's exactly what I find in practice. And for endo, one of the main criteria for success is coronal seal. So having a good seal after you've done your root canal treatment. So if you go through a crown, you don't know if there's a micro leakage thing going on underneath, if there's caries or cracks, all of which will make your root canal fail if something like that's going on. So that's one of the reasons for removing it. Secondly, you lose your orientation quite a lot when you go through crown. So you're much more likely to perforate, much more likely to miss canals. It's very dark working through a crown. So you can't really see very well. So there's a much higher risk of failure when you work through someone's restoration. And even if the crown's recently been done, the main issue with it is maybe the restoration underneath the crown wasn't recently done. So I get referred a lot of patients with crowns, please go through the crown, and you look at it and you think, okay, your crown is great, but I don't know what the amalgam was like under there, because you might not replace that. So for me, I strip everything down to sort of raw tooth, and then I'll do my pre-endo build-up and go through.
No, that's because then there's just always a risk of it going, failing and reinfecting everything. So,
and then if it fails, what are you going to do? Retreat it and now strip everything out? It's such a cost for the patient. It's just, I think it's better to get it right in the first place. That tooth needs a root canal for a reason. So you really want to find out what that reason is. In practice, literally, I remove pretty much everything, and like 99% of the time, I'm glad I've done it.
Okay, so we've gone through access. Okay, so best medicaments and when to use them.
Okay, so probably the main one we use in endo is calcium hydroxide, and you would use calcium hydroxide for anything that's necrotic. Sometimes if a tooth got irreversible pulpitis, that's when you want to pull out something like Ledamix or odontopaste, so like an antibiotic steroid paste.
Yeah.
That sort of paste is useless for necrotic teeth, so you don't want to be putting it in necrotic cases. That's always calcium hydroxide. But the benefit of Ledamix or odontopaste is that it really calms the nerve down if the patient's got a lot of pain. So sometimes when you're extirpating very hot pulps, it can be quite difficult to gain access, you know, without causing a lot of pain and things like that. So they're really good. If you put that into the pulp chamber in the first extirpation visit, in the next visit it will have calmed it down. So that's probably the main two reasons that you use those two.
Next, right, so cleaning and shaping. Okay, so we've got a question about extirpating. So how would you extirpate? We've got release pressure or go to working length. That's what
so again, if it's necrotic, ideally you want to get a file inside the canal. So, you know, that's when you want to instrument the canal. Ideally, clean and shape that canal fully and then place calcium hydroxide. But obviously sometimes you just don't have the time to do that. But you do want to try and instrument the canal if you can. In irreversible pulpitis, obviously if you've got time, instrument the canal, but if you don't, even if you just go into the pulp chamber, that will be fine for that sort of situation, as long as you've released that pressure and put some medicine in the pulp chamber.
Okay.
What was release pressure and the other one? I don't think.
So if it's irreversible pulpitis, the patient's normally in pain because the nerve is inflamed. So when anything inflames, it wants to expand. So the blood vessels will be inflamed, everything wants to expand, and the tooth is sort of a solid structure above the nerve. So if you go in and into the pulp, you're basically releasing that pressure of that build-up that's happened because everything's wanting to expand, can't go anywhere because the tooth's around it. So then you go in and you release that pressure, which helps. For necrotic cases, it can also be pressure sometimes, if, for example, if there is lots of pus and it wants to sort of ooze out of the canal. So sometimes that, again, that's a case of releasing pressure. But most of the time with necrotic cases, it's not that there's lots of pus, just a lot of bacteria in the canal, and that's what's causing the pain rather than releasing the pressure. So that's when you really want to instrument the canal to be able to do that.
Okay, thank you.
I've just looked at the time. We've already nearly come up to an hour. Okay, so
I said to you there'll be loads. It'll be tight.
Okay, I'll try and hurry up a little bit. Okay, so my questions. Crown up or crown down? What's better and why?
So I've never heard of crown up, but is that step back that they mean?
Yeah,
probably. Yeah. So crown down is where you go into the nerve and you basically enlarge the coronal bit as you go down. So you sort of, from the crown down, you literally enlarge coronally and then go further down. Yeah. Step back is where you've gone to the base of the tooth and then you're enlarging basically up. So I think that's what they mean by crown up, but there's no such thing as crown up, it's step back. So with crown down, I would say that's much better. The reason being is, firstly, there's a lot of bacteria coronally and less apically. So if we remove the coronal part first and irrigate and sort of shape that bit first, it prevents us then pushing the bacteria that's coronal down. So if we did a step back, what would happen is that coronal bacteria, if you put a file straight in, you're basically using hydraulic pressure to push it to the apex. And then that's one reason why people get flare-ups after root canal treatment, because there hasn't been much bacteria apically, and you've basically inoculated the tissue with bacteria. So that's one benefit of crown down. The second is we basically get straight line access when we crown down to the more apical part of the canal, because we're flaring that so that our files are going in straighter, and we also have better tactile sensation on the apex of our file. For example, if the top bit was tight and we're putting our file in, you can't really feel what's going on further down because the whole file is bound. Whereas if you have it enlarged at the top, we can now feel exactly what's going on at the apex. So that's some of the important reasons for crown down.
I think I've heard this question be discussed before, but like you've really explained it really well, so it fully makes sense now.
So do you do what we use the Gates linen at the coronal part?
Yeah.
And then you go to the working length.
That's it. Yeah.
Okay.
So you're removing, with your Gates Gliddens, you're now flaring the top, you're removing the bacteria that's there because you've used your gates, you're irrigating, a lot of the bacteria is gone. Now you're putting a file to working length. So you can feel what you're doing with your file. And then you step back. And then, then you can step back.
Okay.
But there is a technique, so there is a technique where you just go straight to length and then step back. It's one of the old school techniques, but that's not the right one to use.
Okay.
Right, so I'm just trying to think because there's so many questions still to go.
Any questions that anybody has as well when we go through it, just pop them in the chat.
No, I don't think we'll have I'm sorry, I don't think we'll have time to go through everyone's questions because I'm just thinking of time. Okay, should we talk about the reciprocation files and Wave Gold and ProTaper? So implications and when to use those.
So just for anyone who doesn't know about the two systems, so ProTaper is a rotary system. So that means that your file will go round and round and round and round. With reciprocating systems, it partially engages and then it disengages, and then it partially engages and then it disengages. So eventually it will go all the way round, but it does it in stages of engaging and disengaging. So rotary systems were a lot more traditional. Reciprocating systems have come out slightly more recently. And the reason is it's a slightly safer system. So instead of everything going round and round and round, it can that tends to lock into the canal. This disengages, so it's basically a slightly safer system than a rotary system. The benefits of it are, again, one, it's safer. Because it's safer, one file systems have come out. So there's only basically, for example, Wave 1 Gold or Reciproc. These are two reciprocating systems. You can use one file and it preps the whole canal for you. So the benefits are it's quicker in a lot of ways, and it can be safer as well. The negatives are you lose a lot of tactile sensation. So with hand files, you have the most amount of tactile sensation. But when you use rotary files, because they're rotating, you can almost feel the canal. Whereas when you're using a reciprocating system, it clicks. I don't know if you guys have ever used it, but it feels a bit weird when you first use it. It's like, it almost like feels like it's cutting. It's like, so you lose a lot of the tactile sensation from using a file. So that's one of the reasons that I prefer rotary systems over reciprocating. But you will have a longer file sequence. So for example, if you look at ProTaper Gold, you've got Shaper 1, Shaper 2, Finishing 1, Finishing 2. So you've got almost four files, whereas with Wave 1 Gold, you're using one file. So it's a lot quicker to use a Wave 1 Gold system, but you lose some of that tactile sensation. So preference, really.
Would you say for more tricky like canals, you need that tactile sensation, whilst for?
I like it, yeah. I mean, you will get some people that will use reciprocating for even really curved canals, but I prefer having that sensation of what's going on at the tip of my file. With reciprocating systems, you lose all of that. You literally just, 3 strokes out clean, 3 strokes out clean. You lose a lot of the sensation.
That sounds like my kind of vendor.
Yeah.
So have you done any hand instrument files anytime recently, or are you just fully using rotary now?
Yeah, so I fully use rotary, but you can only use rotary systems after you've used hand file systems. So you basically want to get a glide path first. So when you start your root canal treatment, you never want to take a rotary system down before you've taken a hand file down. So you need to get to at least the size 10 to 15 to working length. And that's your glide path. It's basically a smooth tunnel from the coronal aspect of the canal to the apical aspects of the canal before you take in rotary systems. So it's always going to be a bit of a mix when it comes to the system that you use. But yeah, after I use hand files, most of the time I'm on rotary files. It takes too long and it's a bit annoying because hand files are quite stiff. So you probably noticed when you've done your endo, your fine hand files, so your size 10, 15 maybe, are quite easy to get to length. But then your larger hand files, sometimes difficult to get to length because they're a lot stiffer. Whereas rotary systems are made of niti, so it's a lot more flexible, goes around curves. You're less likely to ledge and things like that. So I think for me, it's far superior to use a niti system when you're preparing a root canal system.
I don't know what other university system is, but my specific tutor was like, you have to do at least, one of my tutors was like, you need to do at least 3 endos with hand files and then you're allowed to use rotary. And then my other tutor was like, just use rotary, it's fine. And it was literally just like such a much easier experience using rotary.
Do you know what? I think it is smart to that you do a mix, because when you get out in your DF1 year, some of you won't have rotary systems, and some of you will, but they'll make you use hand files initially and then move you on to rotary. So I do think it's good, because some practices just don't have rotary. So you don't want to be in that situation where you've never done one, you know, when you get out. So I think it is smart to have done a few at least with hand files and then move over.
I think when I just did my rotary one, I was like, go through it and I was like, is that it? Like, have I literally just done like the work of like a whole session in just like 5 minutes? But
yeah,
not 5 minutes, but yeah, couldn't believe that. Okay.
I just think you can do things with rotaries that you can't with hand as well, like sharp curvatures and things like that. You just physically can't take a size 30 down that. You'll ruin the canal because you'll straighten it out. So there's definitely a place.
And would you say there's a high risk of them breaking as well, the hand files, rather than rotary?
No, probably the other way around, actually.
Oh, really?
Yeah, rotary files are much more likely to break than hand files. So there's two types of fracture. One is torsional fatigue, so torsional fracture, and the second is cyclic fatigue. So torsional fatigue is basically where you take a rotary file in, or even a hand file, and you're putting a lot of pressure on the tip. So the tip basically locks into the canal. The rest of the file continues moving, and the tip breaks off. Yeah. That's torsional fracture. Cyclic fatigue is where you break a big chunk of file. So that often happens if you don't have good straight line access. So the file is the metal of the file is doing a lot of work through the whole thing, and then you get a big chunk that breaks off.
Okay. Okay, quick. So obturation. We can quickly go into that.
Can we go into chat quickly, because somebody's asked a decent question. Naz asked a really good question, which I think we should go to at the end. And then Nikita asked a question about the glide path. When you use your hand files, do you use pro taper files, which are nickel titanium?
No. So when you do your glide path, you want to be using a 2% taper, so your stainless steel hand files. So pretty much, I'm for most cases, I'll go in straight with a size 10. For very calcified cases, I might try a size 8 first. So you want your glide path to be at least to a size sort of 10 to 15 before you then take rotary files in. So you can get hand files which are night-eye, but it's the stainless steel ones that you start your glide path with.
Okay.
Okay, so preferred obturation method, please. And actually, if you could specifically go into warm vertical condensation, if you could possibly explain that, and then go into what you would prefer to use.
So there's lots of ways to obturate the tooth. We start with single point. So single point is quite often when you've used your rotary system. So for example, what did you say you use? Wave 1 or pro taper?
We use pro taper, don't we? Pro
taper. Yeah. So say you finish on an F2, you then pick up a matching F2 point, get some sealer around it, and put it into the canal. And the sort of benefits of that is it's much easier because you've got one point and it matches your file. The big negatives of it is that the main principles of obturation are: 1, you want a good coronal seal; 2, you want a good apical seal; and 3, you want to entomb all the bacteria that are in the canal within the canal. So when you're using a point which is round, most canals are oval, or they have little sort of isthmuses off them and things like that. If you're just using one point, you're relying on your sealer quite heavily to obturate your canal, and sealer is the weakest part of a root canal filling, the most likely to leak, things like that. So what I would say is single point endo is okay, but it's never the best, because obviously you haven't fulfilled all the principles of obturation. So the second is cold lateral, which is what you guys probably use a lot of. So that's where you get a 2% GP cone, put it to length, and then use a finger spreader to basically compact the cones together with sealer. So you're adding accessory cones and making it sort of a unit of sealer and GP cones. So that's the second one. There is something called warm lateral, which I'm not going to talk about because it's a lot to talk about. Then there's warm vertical, which is the main one that we use as specialists. So that's basically where you put your master cone in. So for example, if you've got a pro taper F1 point, you put F1 preparation. You put the F1 point in the master cone, and then you get a warm, so it's a machine. It's basically like a heated plugger. It's a long metal plugger, and the whole thing heats up. It sort of looks like this, and the whole thing heats up. You put that into the canal with heat, and you take out pretty much the whole cone apart from 5 millimeters at the apex. So you leave that 5 millimeters there, plug down, and that, because you've used heat to do that, that 5 millimeters is slightly warm, so it will compact into the apical part of the canal and fill it really well. Yeah. Then you switch over and use something called an obturer. So that's basically a little machine where warm GP, you squeeze it and warm GP comes out. It's like molten GP. So you put the fine needle all the way to the tip of what you've cut off. So you've got 5 millimeters now at the base, put the tip all the way to the back, and you backfill it. So then you've got molten GP filling the rest of the canal. So you can imagine you've got a really good seal there because the whole canal has been filled with GP. Does that make sense?
Yeah. When we were learning about this, that was literally in my head, like, why do we not have some sort of liquid to just fill it up with? Because then it could literally just fill up every like nook and cranny of it. Because if we're just putting accessory GPs in, like, there's obviously still going to be like little gaps everywhere. Yeah. I'm glad in like actual practice that we can use that. And
yeah, I mean, the only thing is it's quite technique sensitive, and it's quite difficult to use without a microscope. So people do, but I don't know how they do it, because even what happens is, if when you take that first bit out and you've left with your 5 millimeters at the end, if you can't see it's there, sometimes you're not sure if you've pulled the whole thing out. Does that make sense? And then you end up, so it is difficult to do when you can't see right down the canal. It's possible, but I don't know how people do it, because it's quite difficult to do it without sort of very high magnification loops, or with without a microscope. So it's.
I was going to ask why general dentists don't use it more, and it's more of a specialist thing, but I think you've explained it there.
Yeah, the other thing with it is obviously if you haven't, so when you put so if you've got an F1 canal that you've prepared and you're putting your F1 cone in, if you've not got a really tightly bound GP at the bottom, so you've not got really good tug back at the bottom, if you put then a heated plugger down, you can extrude GP through the end. Does that make sense? You're like pushing, because you're putting quite a lot, you're not putting pressure, but you're putting heat. So if your 5 millimeters at the end is really not very, very tight, say you've over prepared your canal a little bit, that can then come out. So that's another reason you're more likely to extrude with it. You have to have a little bit, with with cold lateral, you get a lot more control. You're less likely to sort of overshoot. Whereas with warm vertical, you've got to be very sure that your canal is prepared correctly. Otherwise, you're likely to extrude.
Yeah, that makes sense.
There is a couple of other techniques as well. I don't know if you want me to talk about them, but there's something called thermomechanical obturation, and then there's carrier-based. Do you want me to, or do you want to?
Yeah, just can quickly run through it.
Yeah. So thermomechanical is basically where you put, it's like a file that looks like a reverse headstrom file. So instead of the Christmas tree being like that, it's the other way around. And you put it in your slow hand piece. Does that make sense? And you basically push it down your canal with speed. So it creates heat and it pushes the GP laterally and further down the canal. So again, it's a fantastic technique, but less control, because you're again putting pressure at the top, potential to extrude. So we don't use it that much anymore for that reason. The last one is carrier based. So that's where, I don't know if you've heard of gutter core. So basically you've got it used to be called thermofill, where you had a plastic carrier and then warm GP on the outside. So you have this device, plastic carrier, GP on the outside, you put it in a little oven, it heats up the GP that's on the outside, and then you get this whole device and you push it into the canal, and the warm GP will sort of spread and fill all the space, and you'll get a carrier in the middle. Oh. People didn't like that because it had plastic in the middle, which was hard to retreat. So gutter core came out. So it's basically harder GP on the inside and softer GP on the outside, and you fill it in the same method. I hope that makes sense. I know it's difficult to picture without seeing it. Can you picture it?
No, I think you described that well. Yeah, I can picture it.
Okay.
It's just crazy that people come up with them. But you normally use the warm vertical.
Vertical, yeah.
I think I did hear about that last one, because I heard some. I was watching a webinar and I heard some people saying how like maybe it's used in Turkey or something, and it's
yeah, I mean,
can be
it's used in
quite a
this
nightmare to
country as
remove.
well. Yeah, it's
Stuff
just,
like that.
do you know what, I hate it. It's, I think out of all the techniques, it's the one that you have least control over, because you're literally, yeah, and it's a real nightmare to retreat. So if I can warn you off it, I definitely would.
Yeah, he was complaining because I think he was a specialist and he has to deal with all of those.
Yeah, it's a nightmare. They used to have, back in the old days, they used to have metal carriers. So it went from metal carrier on the inside to plastic carrier to now slightly more dense GP. So you can imagine trying to retreat. It's like taking an instrument out, trying to retreat a thermal,
Yeah.
you know, with the carrier that's metal.
Okay, let's go on to problems. Okay, so what would the best technique be to bypass a separated file? Oh, actually, wait, we've got something in the chat. Is it a problem if the sealant protrudes out of the root apex when the master apical file is inserted into the canal?
No, so that's called a sealer puff. If you talk to a lot of our American endo friends, they like to get a sealer puff. Here in the UK, we don't mind. So for me, it doesn't bother me if I get it. It doesn't bother me if I don't get it. Sealer is quite biocompatible, all the sealers that we have, and they will tend to resorb over time. So in America, they like it because it shows good control. It shows that your GP is to length, but you've still got patency in your canal. So you've still got enough that a sealer can sort of puff out of. And you only really get them when you use warm techniques. So it shows that you've used a good obturation technique as well. For us, it doesn't bother me. I try not to get them if I can, because I think that anything extruded into the apical tissues is never ideal. But if I do get it, I don't mind at all, because it's very biocompatible and your body will naturally resorb it. It won't resorb GP, but it will resorb sealer.
Okay, so the best technique to bypass a separated file manually and how to prevent this in the future.
So I think we talked about separated instruments and how they happen. So we talked about torsional fatigue and cyclic fatigue. So firstly, in terms of to avoid that happening, so like we talked about torsional fatigue, the tip binds, the rest is rotating. So you're using your rotary instrument, tip's bound, it locks, the rest of the instrument's moving, so the tip comes off. The way you can avoid that is don't push your instruments. So make sure you've got a good glide path, and don't try and push your rotary instruments. If they're not going, stop, reuse your hand files, and then go back in with your rotary. It's so tempting to push them, but don't, because that's when you get this sort of fracture. Cyclic fatigue is mainly having straight line access to the canal. So working well, making sure you're coronally flared properly. When you're using your rotary instruments, you can avoid fracture by using them 3 times. So normally you put them in the canal, 3 brushes away from the furcation, take them out, irrigate your canal, recapitulate with a hand file and get patency, and then take your rotary file back in. So all of that prevents blockage, because with rotary instruments, you're more likely to get a lot of debris. So you need to sort of irrigate much more frequently, and get patency in your canal, recapitulate. Also, make sure you clean your rotary instruments really well. So use your endo sponge, examine your file, make sure there's no debris in the flutes, because if there's debris in the flutes, that file then can't cut. If you can imagine, it's got all this stuff blocking its cutting efficiency. So make sure you really clean your rotary instruments up first. In terms of bypassing a file, that's quite a long, sort of a post-grad crazy, like there's a lot to talk about with it. But what I would say is you would use small hand files, so maybe like an 8 and a 10, and you can try and sort of feel your way. You'll sort of feel where it binds against the other file, and you want to not hit the base of the file, but you want to sort of hit just around the file, and you often feel like it's sticky at that point. So you basically carry on working with your hand files, sort of 8, 10, 8 again, 10, with EDTA solution. So EDTA solutions is a chelating agent, so it dissolves inorganic debris, so dentine debris, and you can sort of work your way past the file. But it's quite a long way to answer that question. Actually, I don't know if we could cover the whole of that from the time we've got.
No, don't worry.
Okay. So I think this was another one of my questions that I was always worried about when I take my patient to the X-ray department, that when they've got all their files in their mouth, and then when I'm trying to figure out the working length or just anything like that, then by the time they've walked like this to the X-ray department and sat down and then finally got it that they've probably moved. So how would you kind of suggest that we kind of avoid that? Because I know you don't have that problem because you don't have to take them anywhere, they're all going to get it in the chair, but
yeah, and you won't in the future. It's really annoying at like dental school where you have to like take them so far, and by the time they get there they're dribbling and all this sort of jazz. Poor patients. So I guess the best way that you can avoid that is using a file which is bound quite tightly in the canal. So if your canal is quite wide, don't take your working length radiograph with a size 10. Use something that's bigger, that's not going to be that's not going to have a chance of moving about by the time you get there and when they walk. So you almost have something that's a little bit more tightly bound. Also, if you're using if you're doing, for example, a tooth, you're not sure if it's in the buccal or palatal canal, which canal is which on your radiograph, you don't want to have to take two. You could use like a headstrong file in one canal and a normal file in the other, because on a radiograph you can then tell the difference. You know which canal is your palatal canal, which canal is your buccal canal by the shape of the file that's in there. So those are the sort of two tips I would have for you, but it is challenging.
I wish I'd done that, and I'll put the different files in. That would have been really helpful at the time.
Because if one's long, then it's quite difficult to know which one is long and which one's short.
No, definitely. Okay, so we had a question from someone in the chat. So irrigation protocols for vital and non-vital root canal treatments.
So pretty much the same for vital and non-vital. So we irrigate the tooth with sodium hypochlorite, which is, dissolves organic debris. It's antibacterial. And it's relatively cheap. So that's the main reasons that we use sodium hypochlorite. We normally want to get the irrigant to a couple of millimeters from the working length. So you never want to extrude it because you can get obviously a very severe cytotoxic reaction, bruising, paresthesia. It's horrendous if you extrude. So what you want to do is get your working length. So with an apex locator, say your working length is 20 millimeters. What I do is I make a bend in my hypochlorite syringe a few millimeters short of that. So if you want to be safe, make it about 5 millimeters short. So you'd make a tight bend in your hypochlorite syringe at 15 millimeters. So you know that you're getting to a good working length with your irrigation. Because what we know is if you irrigate properly, your irrigant's never going to get more than a millimeter or two beyond your syringe tip. So if you're only using your hypochlorite in the coronal aspect of the tooth, maybe 3 or 4 millimeters into your canal, you're not actually irrigating the base of the canal properly. So putting that bend in is really useful. But when you do use your hypochlorite, you should be using your index finger to irrigate. So don't ever irrigate with your thumb. Always your index finger, because you have much more tactile sensation here. Always keep the needle moving, never want it bound within your canal. So just as long as you're doing it like that, you want to basically bend your endo syringe.
I always have to keep telling myself, because I'm just naturally going with my thumb sometimes, and I'm like, oh no. So I have to keep telling myself. Okay, so
I've got a question about sealant, because when I was in labs, a fifth year came up to me once and told me to use an abundance of sealant because it looks great on a radiograph. And it popped into my head when you said that sealant extruding through the apex isn't too much of a problem. So I was wondering how much sealant is too much.
You only want a really thin. You only want a really thin coating on your GP cone because sealant is the weakest part of our root filling material. So if you've got a lot of sealant, your root filling isn't actually very, very good, and you're probably going to have voids and things in it. So ideally, if you've got gaps around your point, you just want to put in more accessory points in there with a thin coating of sealant. So literally just a very thin sliver. There's shouldn't be dripping or anything like that.
Okay, mine was drooping.
Okay, so when is the we've only got about three more questions, everyone, so we're nearing the end. When is the optimal time post RCT to prep for a Cospl coverage restoration?
So ideally as soon as possible. So for me, I quite like to know that my patient's asymptomatic, which normally takes sort of maybe a couple of days to a couple of weeks. So then I'll usually prepare for my Cospl coverage quite quickly. However, if you're not sure about your endo, so for example, you're not sure how it's gone, and maybe it's a little bit short, a little bit long, or something like that, then you might want to plan it a little bit later until you have evidence of healing on your radiograph. I never like to delay it that long because there's always a risk that it can fracture in the meantime. So if you are delaying it for a reason, normally it's really important to tell your patient, look, we're delaying this until we've got evidence of healing, but in the meantime, there is a risk that it can fracture. So just have to be very careful with it. Maybe take it slightly out of the occlusion. Or if you can, I mean, at university, you've got time, so, you know, you could put a direct Cospl coverage on it. So just take a couple of millimeters off the top of the tooth and put a direct composite on that top 2 millimeters, because then that will help prevent it from fracture. But yeah, usually I normally tell my patient, you know, as long as it's asymptomatic, we know we're heading in the right direction, get the Cospl coverage done. We'll examine the tooth again in 1 year's time, and we can never be sure if it's healing for at least 1 year, because that takes that long for new bone to regenerate on the radiograph. So we won't know if it's definitely happening for a while. But in the meantime, obviously it can break. So, you know, we want to get something on it quite quickly. But if you're concerned about your endo, then wait, but just fully explain it to your patient.
Okay. Okay, so we had someone who kind of put in a case patient problem. So I've had a patient who attends with pain. Every time I try and complete her endo, it's too painful. So they've not actually got past the cleaning and shaping point. So
do we know what tooth it is?
We don't. Does
okay.
Whoever answered the question, are they on here? Let's have a look.
So sometimes, for example, if it's an upper molar, for example, so an upper 6, we get some accessory innervation. So if it's the palatal canal they're having problems with, sometimes it's because that you've got a nerve supply coming into the palatal root that's separate from the normal injection you'd give. So you'd want to give a palatal injection higher up at the level that root would lie at. And you'll sometimes notice on those teeth that actually then they feel that, and you think, you know, immediately it's better. So you give a higher palatal for ones like that. Sometimes it can be because it's a hot pulp, and it's just very difficult to clean that tissue out because it's so inflamed. In that case, you want to give accessory injections. So normally I'll give intraligamentary injections, and the best place to give those is mesially or distally of the tooth, because that's where the PDL is the widest. So you can use it, you know, the gun that you get, you can use intraligamentaries, and intrapulpal. So for example, if they've got pain, say you're cleaning the root and at 18 millimeters they have pain, normally I'll widen the canal up to 18 millimeters and then do an intrapulpal at that sort of level, and that will get the rest of it. Sometimes it's just a matter of saying, look, I'm really sorry, just for 2 seconds this will be painful, and get some Ledimix on your file and put it into that area, so next time it will settle. So yeah, sometimes it's just physically removing that tissue that you need to do.
Would you delay providing a permanent Cospl coverage if the patient has very poor oral hygiene?
Then I'd probably delay the endo. Yeah, so it's so endo is more complex care, and it should only really be done on someone with good oral hygiene, because otherwise they're just going to get recurrent caries and the whole thing's going to happen again. So you really want to stabilize that patient until they are, you know, they've got better oral hygiene, low caries risk, good periostatus, and then you do the endo.
That makes sense.
Yeah.
Okay, last question. So if anyone's got any other questions, please write them now. But last question is, so what tips do you have to speed up the time it takes to complete an endo? Because I think right now, especially in Manchester, it takes us like 3 sessions, which is like 6 weeks, because we see a patient every 2 weeks. So have you got any tips?
Endo is really about patience. So you do need to, it's hard to rush endo because that's when you make mistakes like separating files and perforating. So do take your time. Just understand that endo does take time. I mean, at an undergraduate level, it's completely normal that it takes you 3 visits or so. So don't stress about it. You will speed up later. In terms of when you graduate, what I would say is there's a lot to set up for endo. So really train your nurse in everything that you're going to need, because the most annoying thing is you're sort of middle of treatment and then they're trying to go and get like this file or whatever, you know, like get everything set up. Normally when I train my nurses, I give them pictures of everything that I expect to be set. So what I want on my tray, what I want out, all that sort of thing. So that will speed you up a lot, because it's that sort of time wasting that's really quite annoying for you. So good preparation. Use an apex locator. and a good apex locator. Just don't use one of those shoddy ones which will give you readings everywhere, because it's really frustrating. If you just get yourself a good apex locator, it will save you so much time on taking loads of radiographs and just getting frustrated on what the length is, over prepping. Then because you've over prepped, you overfill, all of those things. Apex locators really save so much time. And rotary endodontics, that saves you so much time. So yeah, those would be my 3 tips for that.
Perfect. Yeah, I think it's always like that when like you're in the middle of it and you like you forget something or you drop something and then your nurse has to run all the way to dispense to get it. It's just like delays so much.
Everything at the moment.
Yeah, they have to wait in the queue. I remember that dispensary queue.
And they never open on time as well. So at the start, it's like everyone's like trying to get there first to get the apex locator, because it's like
100% remember that. Bringing back so many memories.
Haven't brought us more. Okay,
we've got some questions in the chat.
We'll go back.
And then we'll go back to Naz's question as well at the end.
One, you can ask Naz's question.
We're trying to leave that one to because it's a good question. I like it. So
I finished all of the questions that we had from everyone else.
Okay. So we got a question by R. It's how do you distinguish between internal and external resorption and the different types? That's quite a big question, isn't it?
Yeah. So it's quite interesting, actually. I'm just about to post my story on this on my Instagram, so you can have a little look at that. But okay, so the big differences between internal and external resorption on a radiograph is external resorption, you can normally see the canal walls through it. So if you can imagine your two your lucent canal, it's been a long day, your radiolucent canal, and if you've got resorption on that and you can trace the root canal walls through it, that's external root resorption. Okay. Whereas because for internal resorption, you'll have that line vanish because it's internal. Does that make sense?
That makes sense.
That's one way. External resorption is a little bit more asymmetric normally. So it's not dead on the center, and it's usually expands asymmetrically. So if it looks more like a mess, it's more likely to be external root resorption. Whereas internal resorption, the canal walls usually balloon. So you normally see this nice balloon of it. How else can you tell? For external resorption, if it's external cervical root resorption, there's different types of resorption. So there's external inflammatory root resorption, external cervical root resorption, and external replacement root resorption, which is probably a whole lecture to get into. So I don't know if we could talk about all of that. But yeah, I mean, those are the main signs on a radiograph that you've got that.
Have you got any papers that you recommend on like resorption? Because I was watching a webinar now, I just got completely lost.
Yeah, I'm trying to think.
If not, you could send them to us later.
I'll have a look. There's a really good sort of endo series called Endotopics that you guys might have access to. They are quite detailed, but the resorption paper on there is pretty good. So have a little look at that. They do fantastic and a really good endo series, quite a high level one, but it is really good. Dental Update is really good as well for you guys. I learnt so much of my stuff from Dental Update articles. So I just basically, any review that I wanted to look at, I used to look up in Dental Update, and it always gives a really good synopsis of what you need to learn as sort of an undergraduate.
Thank you, Al.
And you get free access in Manchester, Dental Update.
We do, but we're not given access though. I still have my issues trying to get access. Anyway, that's a problem for another time.
Oh, yeah. I did too. I remember I did too, because you couldn't access it directly through the library, but they have like a password or something if you ask the library people.
Yeah.
You do have full access in Manchester usually to Dental Update.
Okay, so we've got with some of us still at home and not seeing patients, is there any way we can work on improving our skill with respect to perfecting access opening while starting endo?
Can you work on extracted teeth? I guess you can't at home, can you? I mean, the only thing is sort of, I guess when you do go back doing clinical skills lab, I personally think working on extracted teeth is that you learn so much. Like even when I'm teaching now, I normally teach on extracted teeth, and whenever I'm helping students, sometimes I'm learning about the anatomy, and you think, wow, you just learn so much on how to negotiate canals and how to access and things like that. So working on extracted teeth is great. Other than that, it's just webinars really. Unfortunately with endo, you can't do anything at home apart from things like webinars. Yeah.
I think because in Manchester especially, we do it with plastic teeth, so we're not really learning you know, any variations of your like true anatomy from that, which is a bit frustrating. I think just
it's really hard, isn't it?
Like learn like what the kind of shapes of access to do and like whereabouts it is and stuff. That's what I've been practicing.
I guess it's just reading like endo books, articles on endo. Just trying to sort of memorize it. It's really hard though when you haven't had a chance to practice. I just really do feel sorry for you guys. It's a horrible time for you guys.
Yeah, hopefully it'll come back to us somewhere there, but we'll see.
Could be worse.
Yeah.
Do you want to do Naz's question?
Yeah, so Naz's question was about what we're on now, really, COVID. It was how has COVID affected your work, and what's the future for endo in the current circumstances in your eyes? It was a nice one to
so I think endo, we're quite lucky because we work with rubber dam. So unlike sort of prosthodontics where it's like crown preps and things like that, and there's a lot of aerosol generated, for endo, when I'm treating my patients, I normally put rubber dam on straight away, and then when I do the pre-endo restoration, like I told you guys about, I normally have rubber dam on then I take that off and put a new rubber dam on for the root canal treatment. And I feel quite protected actually with the rubber dam on, because I feel like any aerosol that's there, it's usually on my hair, you know, with my hypochlorite that's sort of disinfected everything. So I feel quite safe actually with endo. I think we're lucky in terms of the specialty that we're in, that we have that protection. In terms of my practice, I've cut down how many patients I see. So I used to do 4 endos a day, start to finish. I'm now probably doing 2, because there's quite a long fallow time. So the fallow time's up to an hour. So normally I'm seeing sort of consults in the morning. I do an endo before lunch. It fallows, you know, over lunch. Then consults, and then an endo at the end of the day. And then obviously the end of the day is fine. The masks are horrible. The gowns are horrible. So initially I was using the reusable stealth mask. I don't know if you guys have seen it, but it's basically makes you look like Darth Vader. You know, for girls, you know, like endo is not endo, but dentistry is so unattractive when you're sitting there with like your hair up and this, like, anyway, but it's even worse now with the Darth Vader mask. Anyway, so I've stopped using that. I now use the disposable 3M Aura masks, which are far nicer. You can actually communicate with your patient through that, rather than the other masks. You just basically, they can't hear what you're saying, and it's quite horrible actually, because patients are scared of root canal as it is, and for you not to be able to communicate with them is really difficult through the treatment. So if you can imagine, if it's something like a hot pulp and you're giving an inch pulp and you can't even tell them properly that it's going to be sore for just a second, you know, you need something that you can communicate through. So the disposable masks are a lot better. But yeah, I think, I mean, like I said, for endo, out of all dentistry, I think we're okay. I feel fairly okay with it. The gowns are horrible as well. They're really, really hot. Yeah, I mean, I end up wearing a strap top underneath, because it's just too hot under there. So I think these are all problems that you guys might face when you get back.
I can't wait to come back now.
Yeah, it's not nice. It's okay, it's manageable. I think the when you first get back is the hardest bit. Once you've sort of developed a routine, you'll be absolutely fine, and you guys will have the right protocols in place and things like that. So don't stress too much about it. Yeah.
Okay, that's the end of our questions. Thank you.
Yeah,
that was a lot to ask.
Yeah, thanks a lot. That was really good. I enjoyed that. Hopefully we can do it again or something.
Yeah, it's my pleasure. I'm glad. Thank you so much for inviting me.